I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
62-year-old with interstitial lung disease with IIIA adenocarcinoma of the left upper lobe. Pulmonary function test here, FVC 74%, FEV1 85, DLCO 47%. How do we manage these patients who have underlying pulmonary disease with stage 3A? Again, we don't have the images, we don't have the nuances. Maybe to quickly to Dr. Lanuti first, and your comfort level or your approach to patients like this with 3A lung cancer with underlying interstitial lung disease.
Yeah, sure. We approach these patients pretty cautiously in that the outcomes in patients with ILD with anatomic resections there's much more morbidity and further mortality. So, it really comes down to, the DLCO here is 47%. Is that adequate? Not sure. Again, they need more of a fitness test. Do I have great enthusiasm for taking this patient through a trimodality therapy? No. And so I would probably be shying away from surgery in this patient. It really comes down to a lot of other factors, including fitness and making sure that how functionally are they with their already compromised lung function.
Dr. Curran, your approach for interstitial lung disease patients like this, and whether that alters your concurrent chemoradiation recommendation versus sequential versus your radiation planning altogether.
Yeah, the same way that surgeons would be cautious with such patients, radiation oncologists should be as well. So we need to look at the anatomy of the disease, how effective a definitive plan of radiation could be. I would worry that almost any platinum-based chemotherapy regimen could increase the acute toxicity, and that could include a kind of intermediate-term pneumonitis. So I would rather do sequential chemoradiation than concurrent, and I really want to see where we are on radiation field. The big issue is what can we do to the radiation doses received by a defined volume of the lung. We really want to keep what's called the V20, which is that radiation dose received by 20% of the bilateral normal lung as low as possible, as well as the V5. So those are going to be key treatment planning issues. And again, looking at the tumor gives you some information. They're really digging into the planning. And again, if there's any patient who might warrant proton planning comparatively to IMRT planning, it might be this kind of patient.
Great. And there's a last question that they wanted us to just take a look at: effect on CHEK2 mutation on recurrence risk or toxicities. I had to look this up. CHEK2 mutations, germline mutation, increased risk of breast cancer, prostate cancer. If others want to add in their thoughts on this, I don't know of any data that suggests that this mutation would increase the patient's recurrent risk for lung cancer or toxicities, but I'm opening this up to anyone who may have some other thoughts here.
So as you know, Dr. Levy, the CHEK2 mutations increase the risk for breast cancer, and we probably would see some of those in other cancers as well, including lung cancer. Potentially this pathway is involved in DNA repair, and I think potentially you could see some bone marrow toxicities. I don't know of any data for recurrence risk higher, but these patients are prone to cancer by itself. So that's all I want to add for this. I agree with Dr. Karan that I would do sequential chemoradiation rather than concurrent chemoradiation.
And Dr. Govinda, one last question. I think you've answered this before. Would you add durvalumab on the back end here, given that this would be a sequential approach and that she has interstitial lung disease?
No. I
Okay.
think these patients are at a high risk for toxicities from checkpoint blockade. I would not.